Bismillah ar-Rahman ar-Rahim. Distinguished colleagues, esteemed guests, ladies and gentlemen, it's my great pleasure to welcome you to the second scientific session of this important conference, dedicated to clinical research and cancer prevention in the Kingdom of Saudi Arabia. Today, we are privileged to hear from an exceptional group of experts, each contributing cutting-edge insights into cancer diagnostics, prevention, and treatment. Their work reflects the impressive strides being made across our healthcare system and highlights our national commitment to advancing both science and patient care. We begin with the eminent Dr. Fatma Al-Hamlan, Deputy Executive Director of Research and Innovation at King Faisal Specialist Hospital and Research Center. She's also a consultant in laboratory microbiology, Senior Scientist in the Department of Infection and Immunity, founder and Vice President of the Rafayda Women's Health Organization, and an adjunct professor at Al Faisal's University College of Medicine. Dr. Al-Hamlan, pioneering research on HPV, has been instrumental in driving national awareness, enhancing diagnostic tools, and shaping public health initiatives in Saudi Arabia. Please join me in welcoming Dr. Fatma Al-Hamlan to give her lecture.
السلام عليكم ورحمة الله وبركاته. جازان جنة الأرض والإنسان. أنا ما راح أبدأ قبل ما أشكر أهل جازان وزملائنا في جازان وجامعة جازان لهذه الحفاوة والدعوة الكريمة والاستقبال والروح الجميلة اللي عشناها اليوم معاكم، فيعطيكم العافية. مؤتمر جدا مهم، نتمنى أنه نطلع من هذا المؤتمر بشراكات نوعية، خاصة مع طلاب الجامعة. كثير حضور من الجامعة ومن المستشفى، فنتطلع إلى شراكات نوعية ويكون يعني بداية موفقة بإذن الله بوجود هيئة البحث والابتكار، أيضا السعودي FDA معنا، وأيضا كل الجهات لنخرج بمنتجات بحثية بإذن الله ونوطن الدياغنوستيك، وهي هذا الهدف غالبا من هذه المحاضرات. I'm not sure if you have noticed or not, I have tweaked the title a bit just to go beyond the cervical cancer, because we have heard today about head and neck cancer, and which is very important when we are talking about HPV infection. Most people, they think HPV is only a women's issue. And in fact, it's a male and female issue, and everyone has to be aware. And whenever we are talking about the vaccines, we have to change the narrative. The vaccine protects male and female from, thank you, from 6 different types of cancers. If we look at the top part of the image here, you can look at different types of cancers that's caused by human papilloma virus. It's true that the cervical cancer, it's the strongest association. More than 95% of cervical cancer cases, it's due to HPV infection. However, there are other types of cancers that's caused by HPV. We are talking about head and neck cancer. And it's true, not all of head and neck cancers are caused by HPV, but it's a black box for us in Saudi that we need really to discover and understand. Almost 20% of cancer-related deaths worldwide, it's due to HPV infection. So it's really sad to see this high number when you have a vaccination and early screening programs. On the bottom, you can see all this intervention that's available as early screening or treatment or even vaccination, although still the cancer cases are high globally and increasing. So when we are talking about head and neck cancer, it's the 6th most common cancer worldwide. The risk factors, Dr. Asiri already mentioned that. and I will add to it the HPV infection. There is a rapid rise when we are talking about head and neck cancer, and I will show you some of the trends in the region. And this is, I think it's happening not only with head and neck cancer, but most type of cancers, if not all, there is always a rise. HPV, it has different sites when it comes to head and neck, and usually these are the common sites for the infection. And there is HPV positive, HPV negative head and neck cancers. And the good news is, and this is very important slide, if you leave today with only this information, it's very important. For head and neck cancer, when you have HPV positive case, this is good prognosis. So the whole case will be treated nicely. However, if it's HPV negative, usually the survival rate is, or the treatment is more complicated. And that's due because the infection is immunogenic, the body will clear it, it will be responsive, it will be responsive to the treatment itself, and that's why you can eradicate the virus and the oncogenes in the virus. However, when the mutation in the human itself, so sometimes it's really hard to treat. That's why this is affecting the management of the cases. So Mayo Clinic, actually, they have reported that for the radiation therapy, for example, and instead of taking 6 weeks, when it's HPV positive, it goes down to 2 weeks. So this is why it's always important to do the diagnostic right and accurately. Here is a paper where it looks at the head and neck cancer trends in the GCC country, and they are looking for the Global Cancer Registry and the UN demographic projection to 2040. So again, if you look, here is the incidence, and the other one, it's the death. There is always rise. Are we ready for that rise? Are we ready for the screening? Are we ready for the diagnostic and the treatment? This is something we have to keep in mind. Saudi is having the highest burden, so there is 2 to 3-fold increase. Here is one paper actually explained it nicely, and I noticed that Jazan is number 1. Again, this is the elephant in the room. And if you look at Saudi, there is no active research to talk about head and neck cancer and how to tackle this, even in the top priorities, because this is regional. So you have to have the chance to really focus on research that tackling this cancer. So for the 4 years, 3,000 cases, and again, Hayil the lowest, Jazan is the highest. We have collaboration with Jazan University, with Dr. Jibran Mershi, and we have been talking about the cases that we are receiving at King Faisal Specialist Hospital. So we have started this project where we looked at the 10 years data for all head and neck cancers coming to King Faisal Specialist Hospital. This research is still ongoing, but again, I can assure you that the preliminary data, Jazan is number 1. It's the highest cases that's referred to King Faisal Specialist Hospital. Hopefully next time when we meet, we will share with you more results and more collaborative research between Jazan University and King Faisal Specialist Hospital. Now I will share with you a good news. It's on a global level. If you are following the head and neck research, last week, Brigham and women, actually they have shared the news. I'm not sure if you are seeing it. So there is a blood test identifying HPV-associated cancer 10 years before the cancer happens, okay? So what they are doing, they are using AI, HPV DeepSeek, using liquid biopsy from blood samples that detect HPV-associated biomarkers, and they can detect it. You would say 10 years, how would they know? 10 years before the incident happened. It's basically they are using the biobank. And again, let's zoom out and talk about the importance of the infrastructure and having a biobank. So basically what they have done, they went back to the biobank and they identified a cohort of head and neck cancer patients. They went back to the biobank and they got the blood test. Then they looked for the biomarkers using the cell-free DNA. They looked for the biomarkers, then they connected the dots. They said, okay, those patients, 10 years back, we could tell they will develop head and neck cancer, and they have their negative control. So finally, it's published, and it will be a great tool for two things. Screening, which is not common for head and neck cancer. We don't have any active screening, and we don't expect to have any active screening. However, it will be a confirmation. If you are treating a patient, you can take the liquid biopsy and you can check if he is free from the viral DNA. So these are the important things. This type of research is being done on the EBV, another type of virus. But this is the first time that they are taking it further with the HPV head and neck cancer. Now we'll shift gear briefly on the cervical cancer. So cervical cancer, it's number 8 right now in Saudi. It used to be number 11. And I want you to see the trend, how it's shifting. Globally, it used to be number 2, but due to the vaccination and early screening, it dropped to number 4. However, in Saudi, we are seeing different trend. It used to be 11, now it's 8. The cases, 358 cases. The alarming part is half of them, they die. So the survival rate is very, very low. Globally, when you are talking about cervical screening, it's the easiest to prevent. Because if it's early diagnostic, we always do the pap smear as women, so it's easy to prevent it. However, they always come late, and therefore, the survival rate is very low. And that will take us to this slide. It's not only in Saudi, but also in the GCC country. If you look, only less than 20, I would say 8% of women, they come in early stages, and the rest of them, they come in late stages. Almost half of them, they come in late stages. That's why we lose lives, because it's the late diagnosis and late reaching to the treatment or the hospitals. I will skip this one and I will go directly to one study that's very interesting. And this is, I know Gamra today, she asked about the patient and how we don't get them involved. This is a research we have done through Rufaida Women's Health Organization. This is our advocacy arm. That's where we talk and change the policies. We partner up with Abshir app to do this questionnaire. So basically, we asked 5 questions through Abshir app. So the lady will come and answer our questions. 5 questions we asked them. It takes less than 5 minutes. 8,000 women responded, which is very interesting because they were responsive, and again, they are not knowledgeable or they are not taking action. If you look at the data, the alarming part at least, if you look at the primary clinics, only 0.4% they get the pap test or the cervical screening from primary clinic, which is not the good practice, because the primary clinics usually this where we do the cervical screening or any type of prevention and screening. However, it's not active. We are hoping that with the new model of care in Saudi, the data will be changed. That will lead us to another thing, because women, they said it's really hard to go to the hospital. It's not accessible. We cannot have appointment. We only get appointment when we are sick. When we want to do screening, it's really hard to get an appointment. So this is another advancement in the field when we are talking about screening. It's the HPV self-sampling device. How many of you heard about it? Dr. Jibran, because you are a collaborator, you should know. No, ladies, nothing? Okay, see? So basically, this is where the women, they swab themselves. Okay, so there is no need to go to the clinic. You do the swab and you mail it to the reference lab, and they call you for the results. This is very handy and it's very important for our culture in particular, because sometimes it's really hard for women to go and get screened. So this advancement is very important. These are FDA approved and it has been used in so many countries. During COVID, they were used a lot. So another type of self-sampling, which is the urine self-sampling. Urine self-sampling, it's used here for cervical screening, but also it's used for different type of cancers, including male cancers, either bladder or colon cancer. So all these devices, now as an advocate, I would call it give access to our population, because we really care about access to our population. I want the women in Jazan to get the same treatment a woman in Riyadh will get. And this kind of advancement will ensure the equity, will ensure everyone have access and everyone can take the lead. You don't need an appointment to do it, you just do it and send it. And this is very important to be regulated in Saudi. We can start it as a national level, and this is actually ongoing communication. We should start a pilot going with the self-sampling instead of doing a national screening, going the old way, which is the cytology. Here is another thing in the US. This is FDA authorized. For example, it's the teal wand. You get the kit at home and you do everything, you send it, and again, it's an online consultation, you get your results. Very simple, very easy, and I wish we have to do something like this. For one of our projects at King Faisal, actually we are working on a rapid test. It's like a pregnancy test that's in collaboration with MIT, and it should be supported by the RDIA. So basically we do it as a flow, as a rapid test. You get to know the HPV 16 and 18 within 15 minutes. To do this, it's going to take us at least 3 years. So I hope with this type of collaboration and acceleration, we can get a product out as soon as possible. Now when we are talking about the self-sampling, because whenever you introduce something new, everyone's saying, no, we don't want to be the early adopters. This is actually, we are very late even to have this conversation. 48 countries, they are already doing the self-sampling. And if you look at the orange color, they are doing it with the self-sampling as a full program for screening. And there are other countries, they are targeting the underserved or under-screened population. UK, they are really good, and they have done it with different type of cancers. Whenever you have a crisis in the country or during COVID, they immediately deployed all these solutions so everyone will get treated, so you don't deal with the aftermath after COVID where the cases increase. With the new technology, with the new proposal for national screening, always the problem is the cost. How much is going to cost me to do the self-sampling? And if we look at this study, this is a very well-designed study from England. They did it for 3 years. They are looking for the cost, the economic value. Are we better off with the clinician-based cytology, or we should go with the self-sampling? How much is going to cost us? So basically, they did 3 sample strategy, and they targeted 10,000 women in their national program. And again, their intervention, it's either the clinician collected cervical samples or the urine, first void in the morning, or the cervical swab or the vaginal swab. This is the workflow. It's a bit complicated, but if you look at the top part, which is the clinician collected, it's basically you make an appointment and you go get the cervical screening. Then if you are HPV positive, you do the cytology, okay? However, if you look at the self-sampling, the extra step will be you will do everything at home, except if your results HPV positive, they will call you to the clinic. and then you do the cytology. See the ease they are making it for females, like you are at home, you would know your results, you don't need to come to the hospital. And the good thing and the main outcome they were looking for, it's the cost, of course, and the other thing, how many women they got screened with this program. And they actually, their results showed that more women they got screened in such a program. So the reach is good, and this is what we want. We want to reach every woman. And also the cost, as you can see, it's much cheaper to do it with the self-sampling. And again, logically, if you think about the clinician collected samples, you are paying also for the manpower and the facility. So these are kind of results from economic point of view. Another advancement happened in the field, and that was introduced to Saudi almost maybe 2 years ago. We had a workshop at Rufaida Women's Health Organization, and they were collaborating with physicians. And Al-Habib, actually, they got this machine and they tried it. It's basically optical electrical signal. So no laboratory, you don't need a pathologist. Sorry if we have any pathologists here. We don't need you with this device. Basically, you can read the slides and you can tell if the cervix has normal or abnormal cells at spot. Within 5 minutes, you have 5 minutes, it will be read, and it will tell you exactly if you have a patient that needs to go to colposcopy or the results is safe. So this is something that when we are talking about underserved or area or a region where they don't have the infrastructure or the facility, because I have visited Asir, I have visited Ar'ar, I have visited area where they don't even do pap smear. They don't even have a pathologist who is focusing on doing these things. They are still doing the old methodology on a slide, okay? So having this machine as a point of care in the clinic, that will be very handy. And it will also help to support the infrastructure for the area that they do not have good infrastructure to tackle this important issue. And when we are talking about prevention, we have to be ready. And actually, this is the paper was published by Al-Habib. They already did the evaluation, and they evaluated this device with the standard of care when they are doing just the regular cytology, and they were happy with the results. It is CE mark, but hasn't gotten the FDA approval. With that, I will conclude my talk. I covered 3 things. The most important one is screening save lives. We have to be strategic, we have to be innovative, we have to reach out to our people to get everyone screened and saved. Self-sampling empowers women. It's mainly used in this case with women, but I'm sure it will expand and it will be for other type of cancers because it's already FDA approved. And this will help us to deal with the stigma, with the logistic issues, and reaching the underserved population. Lastly, we are in a forum of research and innovation. Let's mingle and let's talk and let's explore the AI and the point of care diagnostic to accelerate the process and localize the equipment. Thank you very much.
Thank you so much, Dr. Fatma. Very nice lecture. We are also pleased to welcome Dr. Mohammed Al-Qahtani, Associate Professor and Vice Dean for Research and Innovation at King Khalid University and Director of the Central Labs. With over 100 scientific publications in medical physics, nuclear medicine, and advanced imaging technologies, Dr. Al-Qahtani is a leader in both research and clinical innovation. He is also the founder and director of the Cure Oncology Center at Abha International Private Hospital, where he is the forefront of theranostics and personalized cancer care. Please join me in welcoming Dr. Gahtani.
بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على نبينا محمد وعلى آله وصحبه أجمعين. First of all, thank you so much for Jazan University for organizing such crucial and important meeting to handle different aspects in regard to cancer research and cancer care. My colleagues in Jazan University, they kind of like asked me to discuss our story with the Cure Oncology Center at Abha International Private Hospital, which is a story that we would love all the time to tell and to kind of like convey our experience in regard to the challenges, the strategies, the outcome that we are experienced during the last four years. So when we are talking about why we go for Cure Oncology Center, so as Dr. Mshabbab and other speakers mentioned today, cancer burden in Saudi Arabia is rising and increase exponentially. We kind of like start recording even rare cases in a way that we haven't experienced in Saudi Arabia. And when we are talking about Asir as a geographical place, we have kind of like logistic challenges, and the region was quite underserved when we are talking about cancer services. So our vision was to create a center that meets all patient needs locally while aligned with Asir development strategy and Saudi Vision 2030. So when we are talking about the vision and the founding story, we are talking about three main pillars. So we are talking about the founding philosophy that we have followed, which is about establishing an oncology hub where clinical excellence, advanced technology, and excellence of research would preserve, and you can really find under one shelter. And then after building such a philosophy, we move to where we start conducting our ideas in terms of establishing a comprehensive oncology center. And this was the rule for Abha International Private Hospital. So we move the concept, so we move the idea from being a concept to reach to a stage where we can commissioning such ideas, including technologies, manpowers, and infrastructures. And after that, we have what we call the strategic aim. So the aim for Cure Oncology Center, it's not really about establishing oncology services or oncology unit within the services in Abha International Private Hospital, but our strategic aim was to build a model of regional oncologic care that would be followed in the near future in different regions like Jazan or Najran or in the south regions of Saudi Arabia. So when the story started, it was quite very simple and straightforward. While I'm standing with my students in the university, I have received a call. I believe I ruined it. So I have received a call from Sheikh Abdullah Thmeri. He's the owner of Abha International Private Hospital, and he asked me to visit him in the hospital. And he was having a question and saying, why must patients from Asir travel hundreds of kilometers to receive the care they deserve? Which is a big question when we are talking about populations that's about 2.4 million, and we don't have a comprehensive or semi-comprehensive oncological solution that would support them to survive the phase. So my obvious answer was we have quite a big shortage when we are talking about technological assets, when we are talking about manpower, when we are talking about financing, and when we are talking about willing for people to take the risk. So when we are talking about in oncology, people, they are not really consider it as a challenge, they consider it as a risk to start such a project because lots of complications is coming with it. So we had an agreement, me and him. So he said, I told him what kind of oncology center that you are looking for. He told me, I need a facility that would help the patient from being a suspected case to be fully treated case. So I told him this is the wide spectrum of oncological services and it needs quite good financing. Then he said, I will handle the money, you handle the work. And this is what happened. So we have built the biggest and the most comprehensive oncology center in the private sector in the kingdom. The idea, it wasn't really about the building the biggest or the most comprehensive. The idea was raised from the need for such services in the south regions of Saudi Arabia. So when we are talking about the strategy behind Cure Oncology Center, I have kind of like about 7 pillars that's covering all of these points. One of it is them anchored in national strategy. So having such a center in the south region of Saudi Arabia will support decentralized advanced medical services, which is quite crucial. Like the south regions of Saudi Arabia 4 years ago, no radiation therapy services at all, very basic chemotherapy services, very sluggish nuclear medicine services with just basic protocols. But now we have advanced technologies that would help patients to be diagnosed in the right manner and getting the right treatment in the time needed for that. So after that, we do what we call it needs-based assessment. So when we are looking for the need in Asir region or in other south regions of Saudi Arabia, when we are talking about the kingdom in general, we are talking about 27,000 newly cases of cancers. And when we are talking about Asir region in specific, we are talking about 2.4 million of people. They have no services until the born of Cure Oncology Center. And the current situation for them, they just travel to Riyadh or to Jeddah to get them the services. And the outcome for such a thing, it's about 40 to 50% of the cancer patients having experienced delay in the treatment or interruption in the process of curing these patients. So when we are talking about the workforce gap in Asir region or even in south regions of Saudi Arabia, in general in the kingdom there is one radiation oncologist standing against about 500,000 from the populations. I have calculated yesterday just to make sure that number is correct. And I believe it's not really improving that much. So when we are talking about the global standard, we are talking mainly the advanced country, we are talking about 1 against every 250,000 people. And when we are talking about Asir, we are suffering from chronic shortage in oncological personnel who can support the process of diagnosis and treatment. And this is not just in Asir, it's in the whole south region of Saudi Arabia. So we are talking about a great shortage in the radiation oncologists, medical physicists, nuclear medicine consultants, nuclear medicine specialists, medical imaging specialists, oncology nurses. All of these, there is a big demand for them in the region. So when we are talking about the infrastructure that existing in the south region of Saudi Arabia before the born of Cure Oncology Center, in Saudi Arabia we are talking about 2.5 linear accelerators against every million. I believe we have 32 devices, if I'm not mistaken, apart from them the advanced devices that we have got, like the cyberknife and the proton therapy. And when we are talking about the services, the nuclear medicine services, which is the cornerstone in the diagnosis and following the treatment, so we are talking about 0 services in the south region of Saudi Arabia. Till now, we don't have really a comprehensive service when we are talking about diagnostic modalities. And this is one of the difficulties that we are facing because of the availability of the radioactive material. So we don't have cyclotron in the region. There is a project running on now in Lأبحaث. We hope it's going to be running very soon. At the same time, we are working from our side at Lأبحaث International Private Hospital to establish a specific facility for the cyclotron. So we would make sure when we promise the patient that we're going to provide a comprehensive service, we mean it. So we provide it from diagnosis phase until we reach to the post-treatment phase. So when we are talking about one of the pillars for the strategy, which is relating to the workforce and talent pipeline strategy, we have working together with King Khalid University in building a specialized program in medical imaging as well as in medical physics. Also, we are supporting the residency program, establishing of the residency program in the branch of the Ministry of Health in Asir region, so which would help Cure Oncology Center and other oncological services to have local talented that can support them the work in these facilities. So also we have been working in the global benchmarking for Cure Oncology Center when we establish it. So we are following the global best practices, and we have quite a strong tie with different bodies or leading bodies all around the world that would support the process of providing a good standard of diagnosis and a good standard of treatment in Cure Oncology Center. So we have a joint contract with the European Institute of Oncology. So we are sharing different services that including virtual tumor board, virtual clinics, second opinion, helping the histopath work in Cure Oncology Center, and also in the strategic work. Also, we just have established a joint contract with Children Cancer Hospital in Egypt. They call it 57357. And I believe such a collaboration would contribute massively to the services that we are providing at Cure Oncology Center. So also we are considering research as one of the main pillars in Cure Oncology Center. Yes, we are now consuming knowledge, but we are really aiming to produce it and support it. And I believe in this conference we are participating with them for scientific papers. So we're really considering research as one of our main strategic pillars. So in terms of sustainability and regional impact, so we are kind of like looking beyond financing. So we are considering the clinical sustainability for the patients. So when they are seeking for help in terms of diagnosis or treatment, they would find under one shelter in Cure Oncology Center. At the same time, we are considering the economic sustainability for the patients, so which is through reducing cross-regional patient referrals. Also, we are considering the social sustainability by strengthening and supporting families by treating patients closer to their homes. So this is a Cure Oncology Center. It's a center that's established over 4,543 square meters. So it's quite comprehensive. It has got, I don't know if the laser pointer would work. Let me see, not really. Okay, so it has got 5 wings, I would say. So we have a dedicated wing for radiotherapy services. We have 2 linacs from a family, they call it TrueBeam. One of them is a hyper-arc, so we can do various protocols that's relating to the stereotactic radiation surgery. Both devices are supported with cutting-edge technologies in terms of CT simulation. Also, we have a well-equipped nuclear medicine department that has got SPECT CT, SPECT PET-CT, which is supporting patients from different subspecialties and mainly from oncology. We have a well-equipped chemotherapy wing that can host up to 28 patients at the same time, including 4 VIP rooms. And we have one dedicated wing for theranostics. So we are starting now with iodine 131 treatment for thyroid ablation. And I believe the capacity for that unit will be enough to serve all thyroid patients in the south region of Saudi Arabia. So what we are doing now, we kind of like expanding the service by establishing a new facility, which is the cyclotron facility, beside the Cure Oncology Center. We have signed a contract with General Electric to bring us one of their advanced devices. They call it mini tracers, and we're going to use it to produce various radioisotopes that we can use for diagnostic purposes. It's a small in size, but we can use on it solid targets, which would help us to produce a good amount of activity that we can use for therapeutic or for diagnostic purposes. So when we are talking about equipment or how Cure Oncology Center is well equipped, I'm not really counting the machines that we have got, but I'm looking for these machines as enablers in serving the patients. So we are talking about Linacs, which would help to reduce treatment migrations to Riyadh or to Jeddah. We are talking about advanced PET-CT services and cyclotron, which will help us to localize the surfaces and providing good diagnosis for the patients when they need it. Also, we have got the advanced facility for decay tank system, or providing the theranostic procedures for patients in south regions of Saudi Arabia. Now we are working on developing what we call a digital oncology platform, and we believe we can use it to manage patients in Asir, and it will give a good access for different physicians, specialists, people relating to the patients from a medical point of view, to access the details and to know what's going on with their patients, even if they are under the shelter of Abha International Private Hospital and Cure Oncology Center, or in different places that provide them the services in the region. We have acquired a good list of partnerships. We have a strong tie with the Asir Development Authority and His Royal Highness Prince Turki bin Talal. He's a great supporter for the project, and he considers it as one of them excellence projects that's existing in the south region of Saudi Arabia, or mainly in Asir. We are a very good friend with Ministry of Health, which has sometimes ups and downs, but we kind of like survive it all the time. We have a strong relationship with King Khalid University, and I'm a representative for the university in the center. We are sharing knowledge, education, and even experiences and research with them 357 hospital in Egypt. Also, we have a strong tie with the European Institute of Oncology. We have a well-established relation with Wayne State University for histopathology work. Also, we have kind of like a business relationship with New Life, which is a Turkish business that's going to start their work from Cure Oncology Center to the rest of the kingdom. And also we are working with Oryx as a private sector who providing radio traces. This is the end of my presentation. Thank you so much for your time.
Next, I'm honored to introduce Dr. Muhammad Abdurrabbu Jafar, Associate Professor and Consultant in Dental Public Health and Health Economics at Jazan University, and honorary researcher at Maastricht University. Dr. Jafar has authored more than 70 peer-reviewed publications and developed the ISAC paradigm for early detection and prevention of oral cancer. His work exemplifies a powerful blend of academic rigor and innovative thinking. Please welcome Dr. Jafar to the stage.
السلام عليكم ورحمة الله وبركاته وحياكم الله في جازان. I will take you through a project represent one of the major dental public health project here in Jazan University / research. This project started in 2013. The goal of the project is to fulfill the vision of Saudi Arabia 2030, and it's also aligned with the Ministry of Health goal and aligned with Jazan University public health goal to develop an intervention that tailored to the issue of oral cancer here in Jazan region. So before you start any intervention, you have to look what is going on in the world. And if you know about interventions, especially in oral cancer related or behavior related risk factor kind of interventions, it's always targeting the issue of the local area. And here you can find that there is several interventions being in the world. For example, there is something in Brazil, other intervention in India, but all targeted their own determinants of behavior, and it's restrained also by the financial capability. So for that reason, we decided to go further and investigate our own issue, and we were very pleased with having support for more than 250 dentists on board. We have more than 50,000 patients so far, and published more than 25 or 21 ISI paper, and we are planning to go all the way. Data Dr. Mushabbab showed today, you can see that the mouth plus the tongue, it's combined together, may indicate that the oral cancer, it's the highest here in Jazan. The recent data from the specialized hospital here in Jazan have also indicated that 61% of the cases are oral cancer cases. As you also heard, the majority of cases were at later stage, and we have kind of unique gender distribution where male and female are equal. Usually male are higher. Dr. Mushabbab today have shown some kind of decline patterns on oral cancer. That kind of decline patterns, we need to pay attention to it, because it seems that there is old generation where they used to utilize the risk factor, mainly Shamma and Nushuk, and then two kind of generation, my father generation, my generation, where they did not use. Now we are seeing a new trend of higher utilizer. So we may see a kind of drop on the prevalence in 2 decades maybe, and then hopefully not, but I am worried that we can see the trends coming back up. So if you look at the main risk factors, you look at what we call it here Shamma. There is also Nushuk, which is a little bit darker in color and does not stay in the mouth. You see high consumptions. High consumptions in old population or diagnosed cases, high consumptions in youth. Of course, most of the cases are diagnosed cases, so we can only see the odds, and it's increasing the odds. It's carcinogenics, however, until now, we are not sure of the full determinants of why they are utilizing such risk factors. So we know that there is uncertainty of why they are not using it. There is contradictory beliefs. Some of them, they believe it does not cause oral cancer. And some of them receive it as a normal phenomenon. There is a lack of quitting support, and I know that the cessation program available, it's not really oriented to Shamma. We just published a recent paper maybe 2 weeks ago on how to handle Shamma on cessation cases. So it's a little bit complex behavior than just normal smoking. So if you look at the prognosis, I think everyone now know that early stage is better prognosis, simple treatment, better survival rate, even though I agree with Dr. Ihab, the survival rate here is not really measured well, but it's still, in international data, we know that early prognosis has better survival rates, better quality of life, and low of cost. We tried to see how much does what cases cause here in the treatment. If they are at pre-cancer stage, if you take the average, it's between 1 to 3,000 real. Stage 1 goes up to 30,000. Stage 2 and stage 3, which is the majority of our cases, it's around, especially case 4, stage 4 at 1 million. So there is increase, like a very high increase on the cost of the treatment. This is only the direct cost. So if you look at the indirect cost, you add all of that and all of the suffering that the patient receive. This is also excluding the radiotherapy and chemotherapy. So it costs a lot. So if you look at the reason why we are detecting oral cancer at this stage, you can see on 3 main pillars. The first pillar is the dentist. And I think the dentist is the first gate for the issue. And we investigated the dentist very well, and we did a lot of studies regarding the behavior of the dentist, and we found out that the majority of the dentists, they don't examine the mouth fully, full comprehensive exams. There is several reasons, I will discuss some of them later on, but it's mainly behavior related, it's not knowledge. Has nothing to do with the dentist knowledge. So working on trying to improve the knowledge of the dentist is not going to improve the early detection. So this is the main mark we learned. The second one is the patient. The patient, we found that there is a lot of improving on the awareness of the patient so far now, but still we don't know why they are, especially the new patient, why they are utilizing. I had several focus groups last month, and most of them, they just use it with combined with other risk factors, but there is no clear idea of why they are utilizing. And now is the system. Systems, we investigated the curriculum of Saudi Arabia, most of the dental curriculum, and we started with Jazan University curriculum, and we found out that our curriculum was not including our risk factor. So most of the risk factor was in the curriculum was from some other country. So Shamma was not included, Nushuk was not included, and all of that. Now in Jazan University, it's already included. Other university, not yet. There is an issue that we are trying to work with now, which is the main focus, is the referral system and the appointment system. There is an issue with referring the case, delay regarding the case, missing of the case. When the case leaves Jazan, we don't know what is happening. So I think what is missing now for us is the referral system and this kind of work. So the aim of our project was to do something that solve the tobacco use and the oral cancer early detection. And it should be evidence-based intervention that target the health provider, the system, and the patient. We utilize intervention mapping. Intervention mapping is one of the public health well-established method for intervention, and it's very clear in process, very systematic, and we were lucky to have one of the founder of the intervention mapping on board with us on this project. So that kind of plus to us. So we started with the need and assessment. We looked at all the pillars, on all the stakeholders that could involve the issue. We investigated staffs, organization, dental students, intern, dentists, dental patient, tobacco users. And one of the studies that we did regarding the dentists themselves, we had several dentists who are students, interns, dentists, and specialized dentists. We observed their behavior on the clinic. We had a patient who is a dentist and oral cancer, unfortunately. So, and we also had a nurse who acted as a nurse, but she was a specialized dentist, and we found out that only around 19% of dentists have asked for the tobacco use. Less than 30% or 30% did actually examine the oral soft tissue where cancer could allocate, and only 3% have asked about oral cancer risk factor related to our area. We also did an indirect evaluation from the patient themselves. So only around 26% of them, they felt that they were informed of oral cancer examinations. Only 16% they believe they were examined. And to have any kind of education in regard oral cancer or oral health, only 27 of them. So we started creating our intervention. The intervention is called ISAC. I is to inform, S to screen, comprehensive screening, A to advise, and C to connect. And it's tied to our determinant. So what is we need here in Jazan and across also the country. So you have complete oral cancer examination, then you will have tobacco counseling and patient connection. This is the main pillar, and the short-term goal is that dentists will start practicing comprehensive oral cancer examination, and the long term is to have early detection of oral cancer and also prevent of the risk factors, so early detection of the risk factors. Of course, you have to pretest the intervention, and it is score positive on all of the fluorine framework alarm, which indicate that we were ready to go with the intervention. We started the first trial, and we had around 100 dentists. And the first time, you can see the score was low, their examinations, the actions of oral cancer examinations. After the intervention, you can see that there is an improvement, very significant improvement. Female score a little bit more than male. After 6 months, the screening was even better, and male equal to female or a little bit higher. And if you look at the secondary outcome, which targeted the determinant in the beginning, and we found that the awareness was very high, self-confidence, the confidence was one of the issues before, and here it improved very well. Descriptive norm of seeing other dentists are practicing comprehensive examinations, which started in our clinic. When we started first, we did not detect any case in our college, even though we are in an area where we have a very large prevalence. Nowadays, we detect the cases. We reach sometime 11 cases of pre-cancers, which is really good. And then we have self-reported behavior, where the report to website we have what they have done and what kind of cases they have seen. So you look at the process evaluation, we reach around 50% of our sample so far. The dose delivery was very good according to them, very well received, and they felt satisfied, they felt that they can do something now, and they were involving on the examinations. So it's promising. So the next step was for us is to move from depending only on the dentist behavior, which I believe is really important, to creating a tool that also can support the dentist for oral cancer examinations. So, and it's also tailored. So what we did is we tried to automate Isaac. And by automating, we can overcome the issue of the systems, overcome the issue of missing cases at the early stage, and we tested with dentists, with general physicians and family medicine doctors. We received very good feedback so far. So the idea is to have detections of the risk factor at early stage, to try to work with it, and early detection of the cases to reduce diagnosis to treatment time and issues, to optimize the resources, and also to have something sustainable. Currently, we are facing another issue. So I think that this issue needs to be investigated. And we seen a lot of cases coming to the clinic where they show a sign on their mouth changing, a sign that could relate to oral cancer. There is a paper was published by European countries indicate that there is a strong relation between nicotine pouch and pre-cancer. We see the manifestation in the mouth. We don't judge it yet, but I think something that has to be paid attention to it. We looked at the psychological issues, and we found most of the people are utilizing in our sample size, which is large sample size. Most of them, they combined it with another risk factor. So the claim that is helping individual to reduce smoking is not really showing on the data yet. So most of them, they combined it. So they smoke, they use nicotine pouch, and unfortunately with the new generation, they even use it with shama. So I have one of the cases attending with us here it's very interesting. Some of the patient, or even they were doctors, they are utilizing it even while they are sleeping. So the addiction to nicotine is something else. So we may shift from one addiction to another addiction, which is also alarming. I think that this one in particular need to be investigated, not to be another cause for oral cancer in future. Thank you very much, and I hope you enjoyed the lecture.
Ladies and gentlemen, it's my honor to introduce our final speaker for this session, Dr. Wafa Ahmed Khader, a distinguished consultant general surgeon specializing in breast and endocrine surgical oncology at Jazan Specialized Hospital, Oncology Center under the Ministry of Health. Dr. Khader currently serves as head of the operation department and is a dedicated trainer in the Saudi Board of General Surgery. She is also an active member of the breast cancer screening pathway in the Jazan region and the Saudi Society of Breast and Endocrine Surgery. Please join me in welcoming Dr. Wafa.
Assalamu alaikum. Thank you to organizer committee. I give them hard time, but present today evolution of breast cancer surgery treatment in Jazan, and we are discussing our challenges and future directions. This is our outline today. For our topics, most of the background have been represented by previous speaker. Breast cancer is the most common malignancy among women worldwide and especially in Saudi Arabia. Our incidence increasing globally and nationally, and that have been reflected also in our patient incidence. And until early 2020, Jazan, most of the cases have been diagnosed in Jazan and been referred outside to Riyadh and Jeddah, as have been mentioned before. And our modified radical mastectomy was the traditional standard of care. During current years, we have increased more of our awareness and resources. So a recent study represented the breast cancer awareness in Jazan reaching up to 98%. Not yet we are utilizing this data, so we are giving good awareness program, but we're still providing them part of this cure during this, inside Jazan. So surgical management remaining the cornerstone for all curative treatment integrated with systemic therapy. We know, alhamdulillah, since 2015, our region witnessed transformation with establishment of oncology center. So initially, oncology center was initiated in Prince Mohammed bin Nasser since 2015, and it's moved currently to the Jazan Specialized Hospital with an expansion to involve hematology oncology and pediatric oncology. Recently also we have added a surgical oncology department to the oncology center. So since 2015, we shifted more cases from modified radical mastectomy to get less and less invasive surgery, breast conserving surgery, and sentinel lymph node biopsy. This is the incident have been published in 2020. Breast cancer is still the higher incidence among all patients above 40. And unfortunately, we are facing even extreme of ages. We have patient diagnosed more than 70 and patient less than 20 also diagnosed with breast cancer inside Jazan. This point have been mentioned before, that regional distribution and the cancer registry have been mentioned last one in 2020, although the cases in the registry is, for our data, is less than what have been recently or facing during our curative, during our curative services. Actually, the breast cancer cases in the last 3 years reaching more than 300 in Jazan region. So this is the data being collected since 2022 to 2024 from Prince bin Nasser Hospital and in collaboration with the surgical services in King Fahad Center and the Prince bin Nasser Hospital. We can see half of those patients were accepting to be treated surgically inside Jazan. Most of them are still being referred outside, but at least we are getting more patient confidence and satisfaction to be treated inside Jazan. As we know, the breast cancer have been shifted from more aggressive radical mastectomy toward less invasive surgery, breast conserving, since Fisher was labeling breast cancer as a systemic disease. More and more trials shifting the treatment toward breast conserving and further advanced oncological reconstruction. And in the axillary surgery, even less and less from axillary lymph node dissection toward breast conserving surgery, plus even not to do anything in the axilla in special cases. This is worldwide. So Jazan data, till 2020, we are doing modified radical mastectomy only. And since 2015, as I mentioned, with the collaboration of the oncology team, we are getting more and more neoadjuvant neoadjuvant therapy, and we are giving the patient chance to start doing breast-conserving surgery. So the first breast-conserving surgery on sentinel lymph node was done 2022. Late, but alhamdulillah, we're getting, inshallah, near to the standard surgical treatment. So the strength in Jazan, we have high awareness campaign, we have good governmental support, we have established our center care, and we try to overcome our weaknesses. We have geographic challenges, we have limited experience, surgeon, we have cultural barrier and late presentation and patient satisfaction. We try to overcome this weakness, and we shifted our surgical intervention from more extensive to less invasive. This is the general cancer stages distribution among Saudis, and we can see localized disease was a higher percentage through 2021 and 2022, and more patients getting in early stage. But in Jazan, unfortunately, we're still facing late presentation cases. So our metastatic rate is a little bit higher comparing to the other regions in Saudi Arabia, and we are getting more patients in locally advanced stage. So early breast cancer still less than 15 to 20% of our cases. We're encouraging more of early screening, or early detection of breast cancer in early stages. So that have been reflected on our practice in the last year, 2024. Okay, so mobile mammography was provided to reach up to the mountain and even to provided Farasan Island. We increased an early rate detection of breast cancer. We shifted from mastectomy to breast conserving surgery. We encourage our residents and general surgery workers to be more adherent to the guidelines, and integrated with the oncology center and even telemedicine support for more complex and challenging cases. We improve coordination between a surgeon, radiologist, and oncologist, and plastic surgeon. We're still missing a part of having a radiation oncology and reconstructive surgery immediate in our region, but we get a support of MOH to provide those services in a tertiary center. We increase our patient satisfaction as possible, so we give a comprehensive protocol. We are discussing our cases in multidisciplinary tumor meeting. We get an advanced imaging support and patient-centered share decision. Intraoperatively, we are encouraged real-time utilization of surgical, improving surgical outcome, intraoperative frozen section, and keeping our surgical procedure almost near to the standard. Post-operative systemic follow-up with a comprehensive and continuous quality of care. Actually, our improvement have been notable in referring hospital. So still we are referring patient for radiation oncology, and we're giving an excellent feedback that our surgical intervention even matching what have been provided in the other region. So comparing mastectomy to lumpectomy, we know mastectomy is easier procedure, can be done with a general surgery everywhere, but it is causing disfigurement of the patient and psychological impact. Lumpectomy, removing a small tumor with a good margin, and with the support of radiation therapy, we can eliminate remaining of breast cancer cells. Additional to that, oncoplastic reconstruction will enhance the patient's well-being and provide an aesthetic outcome, keeping the patient a natural look of her breast. So this is the incidence of comparing both type of surgery have been provided here in Jazan. So since 2020, we can see the shift from mastectomy toward more and more breast conserving surgery that have been more noticeable in the last year 2024. So half the patient was provided to be a breast conservative surgery candidate. Again, sentinel lymph node is less invasive than axillary lymph node dissection, and we are pushing patient toward breast conserving sentinel lymph node biopsy. It has less scar procedure, significant low risk of lymphedema, and low risk of arm dysfunction. The data in the last year, 2024, showing that higher cases of sentinel lymph node than comparing to the axillary lymph node dissection, and that's even giving us an indicator that our patients start to present earlier than previous years. So we are getting more and more patients with a localized disease rather than an advanced disease. And oncoplastic technique, as I mentioned, it's provided a natural look to the patient, and even that will cause more and more patients satisfied with a surgical result. We're adapting level 1 and level 2 oncoplastic reconstruction immediate, but still level 3 and skin sparing, nipple sparing, we're not doing here in our region, but inshallah sooner we will have the first cases being done here in Jazan. This is the future of breast surgery, adapting a minimal invasive procedure, laparoscopic and robotic assisted surgical excision, especially in a nipple sparing procedure. We heard some cases in Saudi Arabia being done, but inshallah we'll be faster than them, and we do first our cases here in Jazan. So our future direction, we need to move from measuring the incidence toward measuring our quality of service. So we need to assess our current surgical practice in Jazan and identify the gap of being adherent to the guidelines. I need to encourage people to this objective, measuring type of satisfaction regarding the frequency of breast cancer surgery were done, and quality of the surgery in frame of margins, re-excision, and sentinel lymph node rate, and the rate of axillary lymph node dissection, evaluating the time interval between diagnosis and surgery, which is still quite higher in Jazan, delay between diagnosis and receiving curative treatment. So we need to compare our local outcome with national and an international benchmark so we can improve our outcome in Jazan. We will face these obstacles during future life. Let's say short time, inshallah, we will not face it for a long time. Still our patient presented in the late phase. Still we have less in surgical resources, surgical equipment resources, and presenting or non-presenting of further surgical management or follow-up, like radiation oncology and plastic surgery in the region. So we are giving some recommendation to strengthen our early detection and awareness, and giving more advice to younger generation to be strict and following guidelines while you're handling breast cancer, while you're handling breast cancer patient, or at least referring them to the specialized surgeon who can handle the patient in a proper way. And we have to improve our access to list facility that is not provided here in Jazan, and to implement an accurate data registry. So take home message, breast cancer in Jazan shifted significantly from more aggressive toward minimal invasive procedure. Despite the challenges, we have given a good prognosis, and encouraging all to go for further researches, resources, to get our evaluation of our regional outcome. Thank you.
As we conclude this enriching session, I extend our heartfelt appreciation to all of today's speakers for their exceptional contributions. Each presentation has deepened our understanding of the evolving landscape of cancer prevention and treatment in Saudi Arabia and beyond. Their dedication to scientific excellence, clinical innovation, and patient-centered care reminds us of the power of collaboration and the urgent need to continue advancing research and service of our communities. I would kindly ask the speakers to please join me at the podium for the question and answers. We now open the floor for questions and discussion. Please feel free to raise your hand, and the person with the microphone will approach you. Kindly introduce yourself with your name and affiliation before posing your question. Let us use this opportunity to further engage with our distinguished speakers and explore these important topics in greater depth.
Thank you all very much for this excellent session. I'd like to commend Dr. Ehtani. I had the privilege to visit their cure center, and it was actually the state of the art. It will be a great addition to the region, for sure. I'd also like to thank Dr. Wafat. She really made a difference in the region. Dr. Hamlan, so two questions. First one is, what is the rate of HPV positive oropharyngeal cancer in Saudi Arabia? Because I think knowing the answer would help you to know whether you chase viral circulating DNA or tumor DNA. If the incidence is similar to countries like India, for example, versus places like USA or Europe, then ratio should be very low. So I know there's a value of looking after these cases and knowing the percentage. And actually it makes a big difference in treatment and de-escalation of some modalities like radiation therapy in some cases when it's positive. So my question is, what's the ratio? And then if the ratio is not that high, is it better to go after CT DNA rather than viral DNA? Dr. Jafar, thank you very much. A quick question. So after you see those people and you diagnose them with a lesion, how easy is it to refer them to curative care in Jazan? Because I would imagine there will be a lot of barriers, and I'd like to hear from you. And how many of the patients with pre-malignant lesion will transform into frank cancer under your watch?
دكتور انت سويت تحديد للكل فببدا انا.
تفضلي.
سؤالك يعطيك العافيه. It's a very valid point and it's a very important point, and this has been the conversation 10 years or 15 years ago. Whenever we are talking about HPV vaccination in Saudi, they ask us what is the prevalence. In order for us to secure the vaccine, it's a cost. Show me the data. Zero data. And that was for cervical cancer. Okay? It's hospital-based. Every hospital have its own data, different screening, different molecular. Some of them, they are doing it hybridization. Some, they are doing it PCR. PCR more sensitive, you will pick more. So this is the problem we have been facing 15 years ago about the HPV prevalence. We started a study. It was a national study. That's where I mentioned I visited Ara'ar and different regions. just to collect the national data, and the infrastructure is not there. Back to your question about the head and neck and what is the ratio and what is, we don't know. We don't know. Even at King Faisal, we looked at the 10 years, the paraffin embedded tissue, the histology, and we are doing the shaving. We are looking back because they are not doing the HPV testing. They recently started to do, and they did 11 cases, suspect cases, 5 of them were positive, okay? So there is HPV, but they are not testing. They used to do the different with the biomarker, the P16, and also some of the cases were positive. But again, they are not testing, they are not considering the HPV because they think, okay, even if it's HPV positive, there is no treatment. I will go with my treatment anyway. But in fact, no, the research showed you should know from the beginning in order for you to tailor the management. I hope I answer your question.
Okay, I think now it's my turn. Regarding the referral system, I think we are here in Jazan, we have kind of an issue with miscommunication. You have clear idea how to refer, but I don't know if we refer from the university, what is the exact path to the ministry. So we try to trace that, and we have disturbing data. So we have something between 3 weeks to 3 months of delay. I think the focus of our project now, and I think we applied also for the NIH grant regarding that exact point. There is a lot of miscommunications regarding the cases, and also we, for example, from the university, we don't know once the case go to the hospital, Mohammed Nasser Hospital, the Prince Mohammed Nasser Hospital, what is the next? So I usually, if the case comes through me, I call, and it's a really personal relation. So the path to work from detecting an early stage or late stage to the biopsy all the way to treatment, it's not really solid. The other issue is which case go transfer to where. So if we are transferring certain cases to King Khalid Hospital, there is certain cases goes to King Fahd hospitals, some goes to Jeddah, between Riyadh and Jeddah, most of the cases. I don't know personally, I don't know how do they transfer those cases based on what. And certain cases, I call some of my friends to receive it, for example, in dental school in King Saud. So I don't know exactly the path, and I don't know if there is something that's really clear now. The project is to see all the path and what kind of categories or criteria that they are utilizing to transfer each case to where, and also to have a clear patient pathway, so we at least know exactly where is the delay to work with it on the intervention.
Thank you very much. I think the second session is adjourned. I would kindly ask all the speakers if we just want to take pictures with you, if that's okay, and say thank you.
Okay, thanks.
ندعو سعادة الوكيل لتكريم المتحدثين. بروف محمد عريشي. So نكرم المتحدثين دكتورة فاطمة الهملان. دكتور محمد القحطاني. دكتور محمد عبد ربه جعفر. الدكتور وفاء الخضير. ومديرة الجلسة سعادة الدكتورة نسرين الباب. صورة جماعية. And with that, we conclude our first day with two really wonderful sessions. It was a really rich sessions with scientific details, and now we invite you to go for the opening of the poster session in the next room. Thank you so much.